My name is Dr. Edward Evantash. I am an OB/GYN as well as the medical director at Hologic. I recognize the difficulties with keeping up with the latest literature and guidelines that affect our clinical practice. Our goal at Hologic is to identify relevant articles and provide a concise breakdown of the clinical highlights and conclusions. In the March-April 2013 issue of the Journal of Minimally Invasive Gynecology, there is a practice guideline to provide clinicians with evidence-based information about the management of hysteroscopic distending media and fluid monitoring. And this was meant to replace the previous guideline, which was released in 2000. So this is an update from 13 years ago. With hysteroscopic surgery becoming more widely adopted, and with pathology that we are removing being more complex due to advancements in the technology, it's important to understand these guidelines and incorporate them into your practice. The questions that will be answered to help guide your clinical practice include: what should my deficits be and how do I accurately calculate them? What is the optimal intrauterine pressure setting and how do I monitor it? What causes fluid absorption and how can I limit the amount of absorption? It's important to choose a distension media that is appropriate for the procedure with respect to energy source, as well as the distension media that is least likely to cause complications. The high viscosity distension media, which is typically Hiscon, is infrequently used because of its association with a rare complication, anaphylaxis, as well as a high risk of pulmonary edema with only 300 to 500 cc's of absorption. The most common distension media used is non-ionic solution. There are two types of low viscosity media which can be used and are most commonly used for hysteroscopic procedures. The differences are whether or not there are electrolytes in solution. The isotonic solutions include normal saline and lactated ringers. The non-ionic solutions, also known as hypotonic solutions, include mannitol, glycine, and sorbitol. Hypotonic solutions are normally used when monopolar cautery is employed. The non-ionic solutions, normal saline and lactated ringers, are typically used with bipolar energy. The recommendations within this paper are based on the level of evidence found in the data and are categorized as follows. Evidence level A recommendations are based on good and consistent scientific evidence. Evidence level B recommendations are based on limited or inconsistent scientific evidence. Evidence level C is based primarily on expert opinion and consensus. There are some key recommendations within the paper that should be acknowledged. Those recommendations that are level A, the highest level of evidence, include normal saline and other isotonic electrolyte-rich solutions are useful and safer media for even if there is absorption of a substantial volume of solution, normal saline does not cause electrolyte imbalance and consequently is a good choice for minor procedures performed in the office. Normal saline should be used wherever possible for operative hysteroscopic surgery to reduce the risk of hypernatremia and hypoosmolarity. Level A evidence also includes the use of vasopressin. Use of 0.5 units per ml of dilute vasopressin with injection of 8 mLs prior to the procedure, and repeating the injections at 20-minute intervals has been shown to significantly reduce absorption of distension media during hysteroscopic surgery. These are not my recommendations or the recommendations of Hologic. This is an evidence level A recommendation per this article. The use of dilute vasopressin is ultimately at the physician and/or practice's decision. The uterine cavity distension pressure should be the lowest pressure necessary to distend the uterine cavity, and ideally should be maintained below the mean arterial pressure. It's not uncommon that the intrauterine pressure needs to be adjusted to achieve optimal visualization and perhaps tamponade bleeding during hysteroscopic procedures. For elderly patients, and others with comorbid conditions, including compromised cardiovascular systems, a maximum fluid deficit of 750 mL is recommended. For healthy patients, the maximum fluid deficit of 1 liter is suggested when using hypotonic solutions. The maximum limit for isotonic solution is unclear, but 2.5 liters or 2,500 mL has been advocated in the previous AAGL guidelines. Recommendations from this guideline also include monitoring fluid deficit very closely. Now, the simplest method for monitoring fluid deficit is by subtracting the volume collected from the volume infused. Outflow volume can be calculated by adding up all the fluid in the outflow canisters, fluid in the perineal collection drape, as well as fluid that may be around the patient or on the floor. Although this seems conceptually simple, there are many difficulties that may be encountered when trying to calculate all the media, and therefore it's best to use an automated fluid management system. This system should ideally comprise an infusion pump that allows determination and continuous monitoring of true intrauterine distension pressure, and a system for accurate measurement of fluid deficit.